Panel discussion. The topic is transfusion in onco-anesthesia, an area that requires careful judgment, balance, and often prompt decision-making. We have with us our panelists, Dr. Sukesi Nair, Professor from the Department of Transfusion Medicine, CMC Vellore, Dr. Basant K. Raini, Head of the Department of Anaesthesia, Indo-American Cancer Hospital, Hyderabad, Dr. George Kurian, Associate Professor from the Department of Critical Care, CMC Vellore, and Dr. Vinota Thomas, Professor from the Department of Gynae Oncology, CMC Vellore. Moderating this discussion, we have Dr. Arvind Narayanan, Associate Professor and Senior Consultant in the Department of Onco-Anesthesia, Pain and Palliative Care from Adaya Cancer Institute, Chennai, and Dr. Praveen Benjamin Dennis, Associate Professor from the Department of Anaesthesia, CMC Vellore.
Hello everyone, good afternoon. So, our topic for the panel discussion, first slide please. Okay, our topic for our panel discussion is transfusion in onco-anesthesia, thresholds, complications and strategies. Our panelists have been introduced. So we'll quickly go because I think a lot of topics need to be covered. So context-wise, cancer patients are commonly transfused with blood products immediately before, during and after major surgery. Tumor complexity and load, proximity to major vessels, availability of planes for dissection, exposure to chemo, radiation, immunological therapies and nutritional deficiency should be considered. And some of the major problems is, do we cause harm by transfusing, by increasing the load of cancer, and by either reducing the immune surveillance or by directly stimulating tumor growth. And apart from that, we also have to deal with the usual complications of blood transfusion. So we are approaching the topic through a very easy standard way: preoperative, intraoperative, postoperative and long-term outcomes. And yes, sir.
Now that the airway is secured, we are, I think, much more in a better frame of mind to transfuse our patients. Welcome all my panelists over here. It's nice, Dr. Sukesh, Dr. Basant. Okay, so Dr. Praveen has laid down the premise as to why. Is it just a no-brainer that all surgeries, patients bleed and we need to transfuse them? Yeah, in onco, obviously, he has laid down certain ground rules that we are not trigger happy. Unlike maybe the Draculas of cardiothoracic surgery, we are not like that. We don't want to order about 4 or 5 points of this and that and then transfuse everybody. So why is that? Why is that there is some need to understand the blood management in patients coming for onco-surgeries? So that was what was the previous, should I go back a little? Yeah, so I think he highlighted some of the problems. I would start with Dr. Sukesh. We have a list of problems here. What do you think, sir, as a transfusion medicine specialist? Am I right?
Yeah, I'm a hematologist.
He's a hematologist, and I'm sure the onco surgeons and the anesthetists would approach you for blood products. Do you think you're okay to sign off on whatever they ask, or do you think that's something which holds you back from?
I can discuss with them based on transfusion triggers.
Yes, that's an important point to consider.
So transfusion triggers are very important to look at, because you must realize that whatever you're giving the patient is a very harmful product.
Okay, so that's the basic idea. We are dealing with a harmful product. That's why we call it not an infusion, but we call it transfusion. Okay, so there's obviously a cost attached to it. There's obviously it's a product from some other human being. And in cancer, we are a little skeptical about being too liberal with blood. So they approach you very frequently, sir, or they say once in a while they come to you and say we need some blood?
Yeah, so fortunately there are guidelines. So as long as there are guidelines and triggers are defined by that guidelines and people follow the guidelines, we have no issues.
Yes. So guidelines and guardrails. I think with AI coming into the picture, guardrails become a very common word, wherein we have to put some safety limits. Dr. Basant, what do you feel? Do you think our surgeons are always happy to create blood loss? I don't think so, because surgery has developed, especially more and more complex patients, and they come to you and say, sir, we'll have only just about 50 ml blood loss. Are you okay to take up this patient? So what do you feel? Sir is gathering his thoughts, because he'll give you...
there are at sir has said, there are thresholds for perioperative blood reservation and all that. And I think it is the nature of the surgery, the duration of the surgery, history of prior chemotherapy, and BMI.
Absolutely.
These are certain factors that actually decide what would be the requirement for that surgery. And if in case you reserve and cross-match blood, how much would you do it? Or would you just do a screening and if blood is not required to be cross-matched, do you just do a screening and go ahead with the procedure?
Yep.
It all depends on these aspects.
Perfect. I think from today morning's thought, sarcopenia, cancer cachexia doesn't mean we don't get obese patients. Huh? Cancer surgery, we do get patients with BMI 40, 45 and so on. So we cannot use that as a context. And then obviously the type of surgery. It may be a simple surgery but have major blood loss. So what sir is pointing out is that yes, we have to be ready, we have to be cautious. But why are we so cautious? Why are we hyper cautious? If it's maybe a fracture femur, we are not really bothered, 1 liter blood loss and we transfuse. So are there some points in our mind which says that we should not be transfusing or we should not be too trigger happy? The word transfusion trigger was used by both of them. So what do we mean by that? And we mean obviously we are not happy to let them become too anemic. We are not happy to allow too much blood loss because obviously oxygen carrying capacity is what we are looking at. Yet we are not happy to give them a packed cell just at a drop of a hat just because it's available, isn't it? I'm sure Dr. George in the ICU, he also manages a lot of patients coming post-surgery, post-surgical. And I guess the trigger part of it, do you think there's something called a trigger in the ICU? I'm sure you meet post-surgical patients more often than.
Yeah, so in the ICU, definitely we do have certain triggers that we look at. So that depends on what is the indication, what is the patient situation, what particular blood product you are looking at. So for example, if you're looking at transfusing a packed red cell, we do keep in mind, okay, what is the current hemoglobin. We also look at factors like, is the patient actively bleeding right now? So based on a lot of evidence that's available to us that goes back to almost the 1990s, starting from the TRIC trial, etc. A lot of trials have looked at different study populations comparing liberal versus restrictive.
Yeah, but cancer versus non-cancer patients, is your management going to be different in the ICU? You can always give them more oxygen, 100% oxygen, ventilate them. So why give blood and cause problems? Because I think a medical oncologist, everybody do say that we have immune modulation issues, cancer recurrence and so on. So yeah, please educate us if you feel there's something more which you can.
Oh no, we would just follow the same.
Yeah, I think the patient's physiology is important. We need to preserve the physiology, not only intraoperatively as anesthesiologists, but also our critical care colleagues know when to step in, how to step in. And I'm sure also there's a lot of other things happening in the ICU, renal replacement therapy, hemodialysis and so on. So those are also challenges. And then stress gastritis, bleeding, I think things which are non-surgical also to some extent. We're only talking about, from the anesthetic point of view, only surgical patients. What about medical patients? So we'll come to that after I address Dr. Vinoda, who's with us from the surgical background, gynec oncologic surgery, right? So I'm sure that you also deal with patients who obviously, again, in this category of patients, maybe endometrial CA, menorrhagia, treatment post, different kinds of interventions. And most patients would be anemic when you start off. Is that the profile of patients you see here in Vellore?
So most of the anemic patients are the ones who have had chemotherapy and then who come for surgery.
Okay.
The endometrial cancer patients are usually well preserved. They are obese and they have the obesity associated with sarcopenia. But they don't have anemia. Cervical cancer patients, that's one group of patients who typically come with anemia, and that is a prognostic factor for their disease. So the anemic patients I see are usually are ovarian cancer patients who have had about 3 cycles of chemotherapy. And so it's just not anemia alone. They might also have thrombocytopenia and low WBC, leukopenia too.
Okay, so this discussion is not just limited to anemia or red blood cell transfusion. It's also expanding on to maybe platelet transfusion also for thrombocytopenia.
Yes.
And also obviously total counts because we see post-chemo or medical oncologic patients. I'm sure, sir, from the medical oncology perspective, do you get requests from them for most of their leukemias and things like that? Because post or the way time they present, they have pancytopenia. So that will be a major chunk of the blood bank resources which would go towards that. What would you think about that?
Surgical oncology, the transfusion triggers we don't follow that much as because when you say transfusion trigger, okay, this is the right this thing, then there is something called maximum surgical blood order schedule. This surgery will require 3 units of blood. As far as a post-chemo person is concerned, we have a different take on it, because we know that the marrow is not producing.
Absolutely, and so you have to keep supporting them over the period of time, and then the chemo, whatever comes,
then
allow the marrow to sort of regenerate.
And we can't, like somebody's hemoglobin is low, and they'll say, "Arey yaar, isko thoda iron dekar bhej do, 1 mahine ke baad aa jayega." In oncology, it is not possible. You can't say 1 mahina. You have to do the surgery tomorrow.
Yep. So the time-sensitive nature of oncosurgeries. So that gets us to the point that we do get in oncosurgeries a lot of patients who require blood products. That's a given. What do we do now? How do we address the situation? Do you think, sir, anything can be done preoperatively wherein we can prehabilitate them so that we avoid transfusion?
Yeah. Treating anemia is one part of the prehabilitation that all of us follow. So. When we see an anemic patient, we try to see the probable cause, whether it is a nutritional cause, whether it's a deficiency of iron or B12, whichever you look at the red blood cell RDW, then you look at the serum ferritin if you suspect iron deficiency anemia, TSAT, transferrin saturation.
So effectively, you're going to work up the patient in order to identify and then give them anything but a packed red cell. We don't want to give that transfusion to them preoperatively.
Yeah.
But we do, I think, have some patients who are in the borderline of reserve. So we need to maybe give them a transfusion to get them ready for surgery. Maybe it's an outlier, not a regular case scenario.
So you look at whether it could be disease-related anemia. So you do a CRP to see whether there is any inflammatory factor in that.
Yep.
So
I think
do an overall assessment
absolutely,
to find out the probable cause and try and avoid the transfusion.
So we have the same timing, what we spoke about in the morning sessions also. Nutritional improvement of albumin, make them better. I think that is a time window which we can also utilize in order to make sure that we restore their iron levels, increase their hemoglobin reasonably. But do we use the same triggers? Coming back to the triggers, do you think we should use the same trigger as a non-cancer patient, or is it okay to accept? Because we need to urgently get them to OT, so maybe we have to compromise on the.
I think preoperative transfusion we try and avoid at all costs, because again the immunosurveillance depression which can lead to recurrence of the cancer, which has been proven in
Until unless of course they are in
like
high output failure,
cancer.
Anemic failure related. Maybe that's one way where you want to catch them and get them back. So
but they are very specific subgroups of patients.
Absolutely.
And they're not very common. So
absolutely. So we have these many. Then the question comes, what else can we do in the preoperative optimization? Can we do something more when we know that this patient is having a major resection with splenectomy, with maybe a vascular resection and so on? Sometimes we do have compartment resections and things like that. So can we use the same strategies what we use in any other patient? Autologous blood transfusion, acute normovolemic hemodilution, and things like that.
First thing, in the preoperative period, we could use iron transfusions to improve the
to improve the baseline hemoglobin.
Hemoglobin concentration, give supplements of B12 and folate, if that could be the reason for the deficiency. Intraoperatively, if in surgery such as liver surgery, plan for a cell in intraoperative.
I think that brings us to the question of intraoperative management.
Yeah.
So is cell saver or cell salvage a reasonably acceptable technique when it comes to cancer surgeries? Because again, there are, I think, different schools of thought. So whether we should do it or whether it's going to predispose the patient to metastasis, or is it better to wiser to use some of the blood product rather than the patient's own, which we know is going to be. So what are your thoughts on that? Any of you having thoughts on that?
The recent guideline actually says that
Yep.
reduced blood using filters.
Yes, special filters.
There are studies which have shown the incidence of recurrence is no different.
Absolutely. I think in specific large sarcomas, maybe I think some studies have been done with
liver tumors and sarcomas.
Yep.
And you even use radiation to actually decrease the chances of recurrence.
Perfect. And in that context, Dr. Vinoda, do you think sometimes embolizing, using like what we use in I think Bhakri balloons and things like that in PP to avoid PPH. So do you think some concepts like that can work, wherein intervention radiology can help us to sort of
so
reduce
it depends on the case. So sometimes we see tumors which have large, very vascular, or you might have accompanying arteriovenous malformation. In those cases, we might
plug them out.
Embolize. It also depends on the kind of surgery we are doing. If we have, say, example, an endometrial cancer with a hemoglobin of 9, but the kind of surgery I'm going to do is only removal of the uterus, and I'm not going to preemptively transfuse, or I might build up her iron stores because I know it is iron deficiency anemia. For a patient with ovarian cancer, they are associated with peritoneal carcinomatosis, and they usually have normocytic normochromic anemia. They don't have iron deficiency. It's just anemia of chronic disease. In those patients, anesthetists will not accept her, PAC clinic will not accept her unless the hemoglobin is more than 8. For them, I have to transfuse, also knowing that she will have an extensive surgery as compared to an endometrial cancer patient.
Yeah,
so
which brings us back to the point that pre-anesthetic clinic accepting a patient. So we have to give a thought to it. Not that every patient with hemoglobin 6 or 5 should be accepted. At the same time, if somebody is on 7.9 versus 8.1, I think that's always an issue with us. We need to look at it in that context wherein pre-op transfusion may not be the best option, but there are certain other options which we can try. So coming to the last part, which is the long-term outcomes. Why are we talking about it at all? Do we think that transfusing 1 point of blood to a patient intraoperatively can affect the long-term outcome? I think the studies are sort of not very clear about it. So just like opioid anesthesia. So if we are not sure, better not to give. So if we have alternatives, let us use them. So that seems to be the rationale behind it. So with this sort of a baseline understanding of this, can we go to some of the cases and see? So I think we have a 72-year-old man with mucinous tumor appendix, hemoglobin is low, and he's obviously coming for a major surgery. So he needs to be prehabilitated. So this is the right kind of patient, I think, we have time, maybe 2 weeks, maybe 4 weeks, and get things ready. And we have to fix so many other issues also over here and see that they don't go haywire. And maybe this kind of a patient will come to you, sir, with a big list. We need 4 PRCs and 4 FFPs and this and that, because we're expecting major peritonectomies and things like that. So that's something which which most of us would actually understand. But then, considering that sir did make a mention about allowable blood loss and trying to find out how much. So is it based on the patient per se, or is it based on the surgery and the patient together?
Maximum surgical blood order schedule is based on the surgery.
Yeah, obviously that does it come from the surgeon or does it come from the anesthetic team?
So it's based on the data that says that this particular surgery requires these many units of blood. So we have a schedule that, okay, if there is this particular surgery, this is and that's how the orders are made. Of course, then if the bleeding is beyond that, then sometimes the surgery is good. We may get a return of 1 unit of blood also.
Yes, I think that's something which we all play it safe. Patient safety becomes the central point of our focus. So this case, I think, talks about a 75-year-old gentleman, craniotomy, well-controlled diabetic, and so on. And so how do you calculate blood loss? Basically, again, the neurosurgeon, how much is the vascularity? And so we should be ready. Anesthetic management-wise, we know we are going to monitor everything. And I think, what about point-of-care hemoglobin testing? Do you think it's a reasonable option to decide when to transfuse? Is it just okay to do only hemoglobin, or do you think anything more? Dr. Basant, can you?
Yeah, hemoglobin from the hematocrit from the ABG can be used to actually see whether calculate the allowable blood loss. That's one thing that most of us anesthetists are comfortable.
Yep.
And if the hematocrit is less than 21 in a normal patient, or less than 24 in somebody with a coronary artery, I think you would think about planning a transfusion.
Yes, I think this is the same formula which most of our postgraduates would know. We start off with this basic premise and that we need to understand, and then obviously not only just eyeball what is happening intraoperatively, but also trying to be objective. Do you think there's any objective method of measuring the blood loss, Dr. Vinoda? Sometimes have you had a discussion with your anesthetic team? I say 400 ml, they say 700 ml, so...
I've seen them weigh all the mops, count the mops, weigh the mops. But we overcome it by squeezing all the mops right before we're handing it over.
Okay, so we have hemolyzed blood loss. What about the experience with buckets of water during TURP and so on? So I think we have seen enough of all this, but yes, we have to have more objective method of finding out what is. Yes, but I'm sure with the big transplant team and other things over here, we have more advanced point of care options available. We have the TEG, we have the TEG Advanced, we have ROTEM and subtypes of ROTEM. I think it's good to incorporate all that and take decisions more specifically rather than jump and say 1:1:1. What is that 1:1:1? Anybody has any idea? Postprandially, anybody who's not asleep? Yeah, so don't say MTP, then Dr. Vinoda will think of something else. So it's not medical termination of whatever. So it's massive transfusion protocol, yeah. So that's one way of looking at it. Maybe, sir, do you get requests for massive transfusion that likely tomorrow, or do they say, no, the patient has gone to OT, there's a major lobectomy and he's bled into the thorax, we want?
So, just to, I don't know, all of you come from different parts of the country and the world. A massive transfusion protocol or what is known as, what is the other word they use, the shock pack and all those things. They are basically unmonitored transfusion of blood products. It is possible, it is only to be done in places where the unmonitored part happens. If you have a situation where finally the monitoring is going to take place, whether it is going to be 30 minutes or 1 hour, as long as monitoring starts, it no longer becomes an unmonitored transfusion of blood products. So this 1+1+1 is places where there is no monitoring at all.
So effectively it's an empiric thumb rule kind of a thing. Yeah, because we understand the physiology behind it, no point giving only packed cells when you need other factors also. So that seems to be the rationale behind it. But yes, now we have more targeted methods of taking a decision. Shall we go further? We have some more case. Looks like the computer has slept off. We didn't sleep. But sorry? Yeah, you can use it here, not a problem. You want me to read it up from here? That's it.
Protocol on blood loss assessment in theatre. I think there are nice articles which have come from Cambridge from Peter Collins and Rachel Collis. I think there is a group in Chad Hospital which is also working on a group with Oxford on the true blood loss assessment. So all this, the blood loss assessment on, drapes and this thing can be made accurate, but it is not based on experience, based on objective data. So sometimes you may overestimate blood loss and transfuse based on that, and then finally you'll have to bleed the patient in surgical ICU because the hemoglobin would have gone up too much.
Yeah, so too much is too bad, obviously. So we don't want to go to that territory. So we have, okay. So now we start off, it's not coming, I'll read it up over here, not a problem, it's okay. So we saw some of the, we saw the allowable blood loss, but they can't see it. Okay, so we have one more scenario where a patient with chronic kidney disease. Now again, we expect them to have a low hemoglobin. Do we give them erythropoietin? I think they have deficiency of erythropoietin, that's why they're having the low hemoglobin in the first place. So again, we see many of our medical oncologists very happy to use a number of products to get the hemoglobin up and also with the total counts up with GCSF and things like that. What do you think is the role in reducing the intraoperative or postoperative use of blood products?
The role of erythropoietin, did you say?
Basically, again, one of the rescue methods for us to stay away from.
Patients with chronic kidney disease, if you are anticipating a major blood loss, if it's a surgery which involves a lot of blood loss, then probably correcting the iron and the giving some erythropoietin stimulating agents would help. but it would, it could be done as a part of rehabilitation.
Correct.
So that you build up the hemoglobin.
That's right.
circulation.
So we are looking at basically alternatives to transfusing a blood product. So we are looking at different ways, nutritional, pharmacological, erythropoietin specifically, and so on and so forth. Now the point is, sir made a mention about we going little gung-ho and giving a little bit of extra blood. He said we'll bleed the patient. I mean, I don't think we have come into a situation where we have to reduce the hematocrit that way. But still, in between what can happen? Can we have hyperkalemia? Can we have other electrolyte disorders? So we have to be watchful, I think, being circulatory overload. Who knows about TACO? Trump always, okay, whatever, sorry. It's transfusion-associated cardiac circulatory overload. It's not TACO, the other TACO. So we have issues with this, and it comes to the selection of the patient, obviously. And we should not, at the end of the day, deny the patient transfusion of any product, because we have endpoints clinically. You have a patient with ooze, you have definitive thrombocytopenia intraoperative, you do a TEG, and you have to identify it and give them. So the same logic applies, I think, in the ICU. So when you get a patient, how much ever the surgical extent, whatever the duration, whatever needs to be done, needs to be done. So we need to, actually at that point, we are looking at acute care. So do you really, or are you mobbed by the surgical team that, no, don't give transfusion because the recurrence will be high? Is that something which comes to your mind as an intensivist?
No, not really. Like we said in the beginning, depending on what particular blood product we are talking about, we generally have a transfusion trigger. We look at the patient's general condition. Is he bleeding? Is he not bleeding? And that's how the decision is made.
Yes, I think that's a no-brainer that we need to look at the physiology of the patient at that point of time and take a decision. Now, coming to the fact that we have a changing demographic of patients. We have a lot of patients now who have definitive cardiac issues. They have a coronary, they need 2 stents, 3 stents, or they need CIBG. But no, they won't go there. They'll come for cancer surgery first. I think that's a pattern we see very frequently. But more than that, when we take up these patients, what can happen intraoperative? So we have a case scenario here, a controlled diabetic and hypertensive 63-year-old ovarian CA. While induction, ST changes. Is it the slide? Yeah. While induction, ST changes, shifted to cath lab, stented. Oh, good. Patient was on clopidogrel and aspirin. So now how do you balance the risk of stent thrombosis versus intraoperative bleeding? So again, waiting. What are your thoughts? It's not an easy one-step answer for this, but then we have to balance the pros and the cons.
This patient had an acute coronary syndrome at induction. Acute coronary syndrome at induction.
So obviously we didn't proceed
PCI
with the surgery.
was done. So these patients, especially if the PCI is for an ACS and if the left main is involved, they are patients who are at very high risk for stent thrombosis. This is one group that is really high risk for stent thrombosis. So if the surgery is not urgent, the ideal time the guideline now says is if you wait for a month on dual antiplatelets, then stop the continue aspirin and go ahead with the surgery.
Okay. Yeah, sure, please.
So in these kind of patients, I mean, this is where all our high-risk anesthesia clinics and we have a multi-morbidity clinic also coming up, where we also discuss alternate options. Like ovarian cancer usually comes with peritoneal carcinomatosis. Can we give her chemo first and then plan on surgery? So that, we can, she's at very high risk for an MI right now. Similarly, with endometrial cancer, we think of various options whereby we can buy time without allowing her to progress. So
Absolutely.
this is where all these
Correct.
high-risk anesthesia clinics and all help.
Yeah, I think the multidisciplinary discussion of such patients is imperative. And rather than, again, getting them into a situation where they bleed and then you give them blood products and they end up with stent thrombosis. So the cycle is always going to be...
quality of life.
Absolutely, yeah.
So we can't make the patient worse, which is not disease related.
Alternative chemotherapy, alternative cancer therapies can be thought of by time.
Perfect. Okay, then I think we have a scenario about intraoperative coagulopathy. Major systemic inflammatory reaction because of major surgery, massive blood loss, and then you have chemo, and then you have done a HIPEC for these patients. I think, Dr. George, intraoperative management is one aspect, but I think the postoperative, day 1, day 2, day 3, these patients don't behave well at that point. So again, there I think, do we have any special considerations? No, whatever is needed for the patient needs to be done. What are your thoughts on that?
Yeah, usually, so because I work in the ICU, I'll say from my perspective, you have generally three kind of scenarios of patients with altered coagulation parameters. One, they may have altered coagulation parameters, but they are not bleeding. The second scenario is where they have altered coagulation parameters and they need a particular procedure to be done. And thirdly, a patient with altered coags and they are actively bleeding. So how you approach what kind of, how many products you give depends on that. If they're not actively bleeding and they're stable, there's no need to correct an INR of 2.7. If they're planned for a procedure, depending on the INR and how much the risk of bleeding of that procedure is, that's how the decision is made, how many products to give. And of course, if the patient is actively bleeding, then you would want to correct the...
Yeah, I think I jumped a step because this is coming to just before the patient came to your ICU. So this has a sort of breakup of a number of parameters, and then it gives us a more directed method of addressing what is the problem. It's a busy slide. I don't intend to go through the slide, but just to understand that we have so many tools at our disposal wherein we can decide what to give. And I think in this, the outlier would be using cryoprecipitates. So what do you think? Do you think intraoperatively somebody comes to you and say, we need cryoprecipitate for this patient, or is it always a post-operative ICU requirement?
So thing is, the transfusion trigger for cryoprecipitate is usually decrease in fibrinogen or any of the products that is in cryoprecipitate as factor 8 or 5. No, I mean, but you can use cryoprecipitate in the background of bleeding in the background of renal failure.
Yes.
Because there is something called an acquired coagulopathy that can happen in renal failure. Cryoprecipitate can be beneficial. But you must also try to identify what's the type of bleeding. Whether it is a bleeding which is looking primary hemostatic, which is, the you classify them as microvascular bleeding, or, bleeding from all the pores, or if it's bleeding from the, the surgical site. So primary hemostatic bleeding is predominantly to do with platelets, von Willebrand's factor, and hematocrit. So you should try to attempt to correct all of them before you try to decide on something else. Like for example, many of the people look at platelet count and cryoprecipitate, but also try to look at hematocrit.
Absolutely. I think what sir meant is that we need to watch the surgeons more closely. Are they clamping the major arteries on the veins, or they're looking for RBCs? That's a common term we use, because it's ooze, and then obviously it's not amenable to surgical hemostasis. So we look at the different patterns of what we have in terms of the point of care tests, and then we either TEG or a ROTEM, and then we come to conclusion. So a quick slide, I think we have about 5 more minutes to go through. We have a quick slide on patients who are on anticoagulants. What are the thought processes? Because again, these are patients who are likely to bleed. So do we counsel them that, look, I cannot stay away from using a blood product, but I have to titrate it to what is happening? And the surgeons also would know. But asking them to do a minimally invasive surgery and expecting no blood loss may not be the right approach, because we still have to be ready for bleeding. And suddenly they'll say, undock the robo, let's open the patient. So we are back to square one. Okay, I think we will not go into this massive transfusion protocol part, but we know it's all directed by, not by empiric or thumb rule therapies, but by more objective measurements of what we can do. Yes, I think we have one slide specifically for Dr. George. So I didn't want to get him at the end of the case, but sort of through the... So blood loss monitoring in the ICU. Is it commonly the drains that we monitor? Sometimes we have patients, we take decisions, abdomen girth is worsening, things like that. I think that's common, especially in the major saturative surgeries in the onco perspective, apart from trauma and other things. So here again, managing the blood loss, you said you want to again be objective. But drains, what are your thoughts on that? Do you think...
when we get patients in the ICU and we are suspecting bleeding, definitely I do look at drains, but there are a lot of things to keep in mind. Sometimes you may have a patient, the drains may be blocked and nothing is coming out. So that's something that can happen quite frequently, and you have to be careful about that. But like any other thing, like hemodynamic monitoring, we try to refrain from looking at one particular parameter, just drains alone. Even heart rate, blood pressure, these are all good indicators of whether the patient is bleeding. Like you said, look at the abdominal girth, various parameters like that, serial monitoring of hemoglobin. We do use that. If you want it quickly, we have an ABG machine. We can use that it's quite a useful indicator indicator whether the patient is bleeding. So we look at various parameters to decide whether the patient is bleeding or not.
Perfect. So I think we have a list of number of blood products given to this patient. And then obviously the outcome of that is circulatory overload, we have to manage it and so on and so forth. Trally, what are your thoughts on that? Transfusion related acute lung injury. So again, I think, is it more prevalent in the cancer oncosurgical patients, or is it?
I think I defer to...
I think Trally has been eliminated by Government of India by making the cutoff for transfusion of blood at 12.5. Trally happens, there are certain people who can cause Trally, donors. And the most common donors who can cause Trally are multiparas women. And to get a multiparas woman in India with a hemoglobin of more than 12.5, so Government of India has eliminated Trally. So if you ever have shortness of breath in transfusion related problems in your hospital, it is TACO, not Trally.
Okay. So let's remember TACO again. All right. So we had this discussion some time back. We sort of had a brainstorm as to what all things to talk about. There are certain common elements running through all the onco patients and why we should stop back, not give them blood. And so then we came on one particular issue about rare blood groups. And these patients also can come to us for malignancy surgeries. So what do we do, sir? What is the approach? You have a patient with hepatocellular carcinoma, hepatectomy. What do we do? I think Amit will be wondering next what to do. This patient comes. Is it just Jehovah's Witnesses, or you have a number of other reasons also why patients might refuse, or they may have very rare blood groups? I think Sukesh has pointed out O-negative blood group.
Yeah. So, at this 52-year-old person comes with a malignancy, going for surgery, major surgery, we advise the surgeon that please shift to, because we know that surgery will only use maybe 2 or 3 units of packed cells. But suppose there's a complication in surgery, we need to shift. We can't give any more negative blood. We need to shift to, so we counsel the surgeon first that there's a possibility that we may have to shift to O positive blood group, which is more commonly available rather than negative, because the blood bank doesn't have good stocks of negative blood. So the surgeon gets worried, the family gets worried. So the issue is that, yes, it is not appropriate to transfuse somebody who is O negative and doesn't have anti-D to give and D positive blood, because they will become anti-D positive. But that doesn't mean that they will never get transfusion in their life again. When they come next time, they can still be transfused O negative blood, because they are only anti-D positive.
And why do we talk about this in the cancer scenario? I think likely that these patients might continue their oncologic.
Yes. So next time when they come, when they discharge them, you said that next time you come, at least bring 5 to 10 people who are O negative. Because there is a good chance he may have become anti-D positive. If he has never become anti-D, there is a small chance that some of them don't become anti-D positive.
So
good
I think
for
this
him.
is a good way for compliance also. They come back for treatment, they come back for follow-up. We say you get some donors along with you. So I think.
And any blood bank in the world can identify anti-D.
Yeah.
So RH immunoglobulin cannot be given because you're giving red cells to a patient who needs red cell. So you can't give, ROGAM, because you're going to destroy the same red cells the patient needs. So ROGAM may not be of utility at that time because patient needs those.
So that gets us to the next slide, which is the most interesting slide. It doesn't say thank you, but I think we have come to the close of this. And most of us will be breathing a sigh of relief. Okay, enough of this blood transfusion and triggers. We'll sort it out when we'll cross the bridge when it comes to that. But yeah, I think the information behind this is that there are certain aspects to consider. We need to read up about it. We need to be aware of things. We need to have a multidisciplinary thought process. We work with surgeons, we work with medical oncologists, and we have to understand that this can happen even for non-surgical issues. I'm sure you do bone marrow taps, you do bone marrow studies in small kids, pediatric age group. They also have compromised hemoglobin, high counts, low counts, things like that. So it's also a medical oncology team who needs to understand what we are talking about, why we say that. I think they are more liberal and they don't think much about tumor recurrence and all that thing, but we have to be on the same page as they are. Thank you all. Thank you for this. Thank you for listening to some amount of, sir.
Thank you to our panelists for that very practical and thought-provoking discussion.
Like you mentioned about this MMBA. ongoing blood loss. So you cannot start your blood when you're actually will reach, and that time we start within may go into the decomposition from very early. So whenever there is ongoing blood loss, you think that a patient may live beyond, then we start blood very early in the period. Yeah, but sir, I hope they don't take the message that next time they'll start saline and blood at the same time, beginning of the surgery, prophylactic blood loss, blood transfusion. So normally what we do, normally start when you're half of MBBL reach, then you can start the blood because you know that you're going to be beyond that. And then you need to give blood. So start early, that will help. Yeah, I'm sure the vascular resections, the bony resections, these are the areas which you look closely. And also look close at our gynae onco friends. They'll be operating inside, but we need to be with them. Tachycardia, watch inside what's happening. Look at hear the suction. So you need to sort of catch up and not wait. That's what sir was saying. Not wait till 800 ml is lost. You try to act starter.
Systolic blood pressure is around 90. Your heart rate is going about 110. I think these are things that connect.
I somehow also found the diastolic blood pressure because we try to give a lot of crystalloids during this process and think the systolic is maintained, but the diastolic slowly starts dialing down. So that gives you a fair idea that look, the patient is getting hemodiluted. So there's a time you need to catch up on.
Maybe you need to look beyond the blood loss. You need to see whether the patient is stable or not, hemodynamic stability. And
no, but sir, there's a lot of confusion.
Whether you need to have increasing support or there is an increasing lactate. So based on that, you need to start transfusing.
No, but after listening to our post-chemotherapy medical oncologist who spoke in the afternoon, he says a lot of drugs cause labile blood pressure. Now, we don't know whether it's because of the autonomic neuropathy or the diabetic status, or is it actually our surgical friends who are causing this blood loss. So we have a lot of territory to cover over there, but he's right. Our patient is the focus of our attention. And then our decision should not be held back because it can cause immunomodulation and all that. No. Treat the patient, treat the physiology, and that's primary. Even postprandially, everybody is vigilant. Thank you all for being with us. Thank you for this. Thank you, sir.
Thank you, sir. I request Dr. Arvind to give away the mementos to Dr. Sukesh.
I gave them so many questions, you want me to give the memento also to them?
Specifically thank Dr. Sukesh to spend his birthday afternoon with us. Happy birthday, sir.
Dr. George. And Dr. Vinota. I also request Dr. Samuel to hand over the mementos to Dr. Arvind and Dr. Praveen.